This is becoming very important information you need to learn. This deals with sympathetic and the parasympathetic division. A lot of your drug targets will focus here. That's why I want to spend a lot of time discussing this. If you understand this, you will understand a lot of the pharmacology that will be needed, right? As you learn all these different medications. So first of all, very important thing, you notice your sympathetic nervous system, your sympathetic motor tone, right? Where does all the sympathetic divisions or nerves come from? Can anyone see?
Thoracic and lumbar.
Correct, right? So as you see, right, they're coming from the thoracic and the lumbar region, but the parasympathetic division, right? You see, it's from the midbrain, brain stem, right? Division. So what can happen is, right? Why? Well, let me ask you this: why is this important? Why is it important to know that the sympathetic division comes from the thoracic and lumbar area, and the parasympathetic division is from especially there's a, well, maybe this will give you a clue. For a male patient in trauma, when you get to the pelvic area, there's something you test.
Or priapism.
Yeah, and
Incontinence.
so yes, so incontinence, priapism, right? So the reason you do this, right? Imagine he has an injury to the thoracic or lumbar area, right? And that was the sympathetic tone, right? But now if there's an injury, let's say there's an injury to this portion here somewhere, right? If there's an injury to this portion here, he may lose the sympathetic tone, and he will have unopposed parasympathetic tone. And parasympathetic tone, right, is the relax and digest pathway, right? The under parasympathetic system, you guys learned sympathetic was fight or flight. The parasympathetic you learned was rest and digest in your EMT lectures, probably, right? So what we see is that we will have no sympathetic tone, and we'll have unopposed parasympathetic tone. So, and the sphincters, right? The sphincter tone may be a sympathetic control. So you have incontinence, you may have priapism. So that's why we test that. Very important to understand that. Right here, we actually see all the innervations, how they originate from the thoracic and lumbar, and what do they innervate. We see, right, as the motor neurons come and they synapse, and the final neurotransmitter for the sympathetic nervous system, post-ganglionic, will be norepinephrine. So norepinephrine is your primary player here. Some things that you want to be familiar with is what the response is, and some of the receptors, right? Some of the receptors that will be triggered. So remember one heart, Beta1 receptors. You have two lungs, even though there's only one they picture, but in your body you have two lungs, so they have Beta2. And then you want to tell me if I have norepinephrine, right, coming to the heart for the Beta1, what type of an effect should I be expecting?
Increased heart rate.
Okay, so what else besides the increased heart rate?
Better contractility.
Yeah, so you will have, yeah, your force of contraction will increase, your heart rate will increase, right? The velocity of the contraction will increase. For the lungs, when you stimulate Beta2, you're going to have bronchodilation, right? If you Beta2 receptors also on the smooth muscles, they will cause some dilation to that, right? Here, you're going to learn in the renal chapters, if you have stimulation of the kidneys of the Bayer response, right? It's responsible for blood pressure regulation. We're going to spend a lot of time talking about that. On the urinary bladder, right? It's responsible for the sphincter tone. On the, right, your anal sphincter responsible for the sphincter tone. So we check, right, for incontinence, because if you lose those innervations, the sphincter may be diminished or lost all entirely, right? So that's why we see that. In the liver, it may stimulate breakdown of glycogen. So norepinephrine, right, in the setting of hypoglycemia, right, norepinephrine can come and start to break down glycogen, so more glucose will be available to the bloodstream, right? So we see all these innervations that are coming in. Now, the other side of it, the parasympathetic system, right? The parasympathetic system, there's no origin, and so all of it is midbrain, right, pons, and the sacral regions. The responsibility of the parasympathetic system is essentially rest and digest, right? The major neurotransmitter is going to be acetylcholine, right? And in these heart, lungs, right, the target receptor is muscarinic, right? Muscarinic. We learned in the muscles it was nicotinic, but in these locations it's going to be muscarinic, and it's going to basically the opposite of the sympathetic system. It's going to slow down the heart rate, right? It's going to increase secretions, pulling of the secretions. That's why in a setting of asthma, right, you're going to learn, combi vent treatment, right? We give albuterol and we give ipratropium. It's like a combo system. The albuterol is a beta2 agonist, right? So beta2 agonist will do what to the lungs?
Bronchodilate.
Bronchodilate. And then I give you ipratropium, which is a parasympathetic. I stop the parasympathetic division from being active. So if you have secretions that are coming out, right, I will dry you out and stop that, formation of those secretions, right? So these systems. Well, let me ask you this question. Right now, you're sitting, you're watching this lecture. Which of this system is working? Sympathetic or parasympathetic?
Both of them working.
Yeah, both of them working. So Almi is 100% correct. They're both working, and they're both working because you're gonna have to have some vasomotor tone. So you're gonna have to have the sympathetic release to have your blood vessels, right? Because you want to maintain some sort of a blood pressure. It's gonna maintain some sort of a control on your heart rate and your lungs, right? In your parasympathetic system, right? Perhaps you ate a meal recently, right? Or you're drinking something, right? Eating something. So they may be causing your GI tract to have some peristalsis, right? Working at the same time. At the same time, you may be, making urine that's going into your collecting duct and so forth. So to say is, you have both parasympathetic and sympathetic system actively working at the same time. There is a balance between them. But what you want to remember, if there is an injury or trauma, or will give you a medication that blocks a certain system. So if I give you a medication that blocks the entire parasympathetic system, then you have unopposed sympathetic system. So see, right, all these things that sympathetic system much more heightened, right? Same thing if I block your sympathetic system, right? For example, you sustain trauma, right? And you go into neurogenic shock, right? You lose your vasomotor tone, right? I'll check your blood pressure, hypotension, right? You don't see that rebound tachycardia. Because why? Because you don't see the rebound tachycardia because you lost the tone. You're not supplying that norepinephrine.
Excuse me, Nick.
Yeah.
What does tone mean?
Tone. So I'll do it like this.
Thank you.
Imagine this is your heart. This is your aorta. And these are your arteries. Right? So this was heart. This is your aorta. These are your arteries are under constant tone. Constant tone under alpha-1 receptors by epinephrine or norepinephrine. It means what does that mean, right? Let's say you were sitting down and you suddenly stand up, or you were laying down and you suddenly stand up. On those receptors, right? Your body senses in position, change in pressure, right? Baroreceptors, and you have secretions of norepinephrine. Norepinephrine is going to come, it's going to bind on these alpha receptors, it's going to cause vasoconstriction. You will not pass out, right? You will stand up and you will go to do your tasks, right? Now imagine you got a patient and he newly was prescribed medication that block alpha receptors. Let's say they give him medicine that blocks alpha receptors. And he goes, takes the medicine, right? And he suddenly stands up from his bed and then he syncopies. What do you think happened?
He lost tone and went hypo.
Yeah. He lost tone and he went hypotensive. Because why? Because if you give a alpha-1 receptor blocker, you cannot accommodate in time. So you lose your vasomotor tone by the sympathetic system, right? And you may syncopize. So the tone that I'm referring to the vasomotor tone exerted by your sympathetic nervous system to basically maintain a certain pressure in your body, whatever it may be, 120 over 80, 140 over 80, 136 over 90, whatever homeostasis for you, right? So that you can perform your activities of daily living. And if you change positions from lying to sitting to standing, right, you don't pass out, you don't lose consciousness because of this balance between the parasympathetic and sympathetic system that's constantly working together in your body. Okay, does that answer your question? All right, since I hear nothing, I assume it answers your question, right? So
Oh yeah. Thank you. Sorry.
all right. So the receptors for the sympathetic system that you guys want to be very crystal clear. You want to know beta1 receptor, you want to know beta2 receptor, you want to know alpha1 receptor. For now, we're going to keep it basic, and these receptors know their function. When norepinephrine or epinephrine comes and binds, beta1 is going to increase heart rate, is going to increase stronger contraction, is going to increase the velocity of conduction. When norepinephrine or epinephrine binds to beta2, is going to cause bronchodilation, right, on the lungs. For alpha1, if it comes, is going to increase the vasomotor tone. So if I have epi that's binding on the alpha1 receptors, it's going to vasoconstrict. It's going to cause these arteries to constrict. If these arteries constrict, you notice, right, they have resistance to blood leaving. If there's resistance to blood leaving, it will increase your blood pressure. So stimulation of alpha-1 going to cause vasoconstriction, increasing your blood pressure. So those are the beta-1, beta-2, alpha-1. Okay. The next thing we're going to talk about, right? So we talked about that. So here the effects of the sympathetic activation. We said that it was flight or flight, increase alertness, right? If you have excessive amount, right, increase energy, euphoria, right? People who take cocaine, for example, euphoria and high alertness. Why? Because it definitely stimulates increased symptoms. Those patients also have cardiac arrhythmia. We see increased activity of the cardiovascular system, respiratory system. And basically, we are on alert, right? In muscle and liver cells, I said norepinephrine can break down glycogen into glucose. It can turn glycogen into glucose. This is important in diabetics, right? In diabetics who experience, right, hypo. If you check their, heart rate, their heart rate is elevated. Because norepinephrine is being released, right? And they are trying to break down, right, their stores, right, glycogen stores in the liver. If we look at the parasympathetic activation, right, parasympathetic is the opposite, is going to be rest and digest. What it will do, right? Perhaps you heard this mnemonic sludgem. So if you have increased parasympathetic system, you have increased salivation, lacrimation, urination, defecation, gastrointestinal disorders, emesis, and meiosis, right? Here, constriction of the pupils, that's it's by the parasympathetic system, right? Secretion of the digestive tract, so increased secretion. If you have increased secretion of the digestive tract, you may have gastrointestinal disorders, right? We see changes in blood flow and glandular activity, sexual arousal. Why? Because it's predominantly by the parasympathetic system, right? We check for priapism, I just said, right? When you have damage to the sympathetic system, you have parasympathetic system, and that's why you may see that priapism developing. Increased smooth muscle activity in the GI tract, so we have peristalsis going on. We have defecation, right? You have contraction of the urinary bladder. If urinary bladder contracts, right, you have urination, right? Constrictions of the respiratory passages. So that's the parasympathetic system, and you may feel that, right? Perhaps you guys also learn of organophosphate poisoning, and the signs and symptoms would be sludgem. By the way, what medication do we give in the case of organophosphate poisoning? I know you guys do it in the BLS level.
Atropine.
How does atropine work?
It blocks the effects of the ACH receptors, I think.
So it blocks the parasympathetic activation, right? So it will it will combat all these effects. It will stop salivation, lacrimation, urination, defecation, emesis, meiosis. So then if you block the parasympathetic activation, you have unopposed sympathetic response. So hopefully this will reverse some of these effects that were induced, right? So they become parasympathetic, they work in opposition to each other. This here, right, the next slide that I want to focus on, very important for you guys to learn, very, very crucial, right? We talked, so let me just point on the key here. The red color is epinephrine. The green color is norepinephrine. The difference is one is a neurotransmitter. The other one is essentially a hormone that's going to be carried in your bloodstream. It's a little bit slower response, but essentially the effects will be similar. And then you have acetylcholine. I think that's the black arrow. So let's go to the ones, right? On the parasympathetic side, the preganglionic neuron, right? The preganglionic neuron that comes all the way here for the parasympathetic ganglion is going to carry acetylcholine. And the release here is also acetylcholine. You notice it's black arrow and black arrow. So both being acetylcholine on its target sites. So on the parasympathetic side, the preganglionic neuron, right, and the postganglionic, they will both have acetylcholine as the neurotransmitter. However, if you look at the sympathetic side, the preganglionic here has the black, it's carrying acetylcholine as the preganglionic. But the postganglionic here, post being norepinephrine, or it could be epinephrine, depending goes to the side, being, let's say, this could be adrenal medulla. So finally, you have a secretion, right? Secretion of norepinephrine there. So, cool ways. Parasympathetic system, the preganglionic, acetylcholine, postganglionic, acetylcholine, neurotransmitter. Sympathetic, preganglionic, ACH, acetylcholine, and postganglionic will be epinephrine or norepinephrine, depending on the target site. All right, hopefully that's clear. All right, here, this is sites of the neurotransmitters, what is actually occurring. So here we see, right, norepinephrine coming out. So this is the sympathetic system. Here we see this is being parasympathetic system. Let's go for the sympathetic system first. Sympathetic system, I said the post will release norepinephrine. Norepinephrine binds to the alpha receptor. If the arterioles, alpha is going to do what to the arterioles when norepinephrine binds?
Gonna cause vasoconstriction.
Vasoconstriction, very good. On the beta receptors, depending, they don't give you a division. If it was beta1 on the heart, increased heart rate. If it was beta2, bronchodilation. Right? Cholinergic fibers, same thing. Cholinergic is the same as acetylcholine, right? Cholinergic system, parasympathetic system. They will secrete acetylcholine. We talked about the nicotinic receptors. Nicotinic are found in muscle, right? Under your voluntary control. But the other side of it was muscarinic. The muscarinic was found for receptors such as the heart rate, right? And it will cause decrease in heart rate, right? It will slow down the heart rate. So muscarinic, cholinergic receptors slowing down the heart rate. Nicotinic here, we saw found predominant muscle tissue. Right. Some of the effects that are here, right? So sympathetic system, preganglionic, as I said, right, was acetylcholine. Postganglionic, right, usually secrete norepinephrine normally. Less commonly, they will secrete acetylcholine and nitric oxide. We're going to learn about this once we do cardiac chapter, right? Nitric oxide donors, what effects they exert. But for the now, what you want to remember is preganglionic is acetylcholine, postganglionic is norepinephrine. That's the sympathetic side. The parasympathetic side, as I said, right? The preganglionic being acetylcholine and postganglionic being acetylcholine. Right. So this is the major stuff you want to remember. Sympathetic fight or flight system, and the parasympathetic being rest or digest.
So can you repeat that?
Yeah. So what you wanna, the major takeaways between the sympathetic division and the parasympathetic division is this. You're on the sympathetic division, sympathetic system, your preganglionic fibers being acetylcholine, postganglionic fibers that actually come and they make the connection to the actual sites like arterioles, heart, lungs, they will secrete norepinephrine. The effects of the norepinephrine will be increased heart rate, increased contractility. If it's lungs, it's going to increase them, right? So norepinephrine will be postganglionic, and it's going to be fight or flight response, alertness, right? And all those things we talked about. On the para side, what you want to remember, the preganglionic is acetylcholine, postganglionic being acetylcholine once more. The system is rest or digest, right? If acetylcholine, for example, was binding nicotinic receptors, we learned that nicotinic is predominantly found in the muscle tissue, the somatic system under voluntary control. If acetylcholine comes and binds to muscarinic receptors, for example, on the heart, it will slow down the heart rate, right? The neurotransmitter being acetylcholine. Right? So these are the major takeaways for you guys, right? The reason why I want you to know the receptors, right? Why I spend all this time talking about beta1, beta2, alpha, right? Alpha1, muscarinic, nicotinic. Then you're going to learn, right? As you progress in the course in the pharmacological setting, we're going to learn about beta blockers. We're going to learn about calcium channel blockers. You're going to learn about alpha blockers. You're going to learn about agonists that potentiate nicotinic effects, agonists that potentiate muscarinic effects, right? And what medications we give. We just gave an example of atropine, that the sympathetic division. So you need to know what's the normal action, what's the normal body's response, right? What's the normal body's response? And then when you activate it or you block it, either agonist or antagonist, what's going to happen, right? So for now, you want to know the normal, what's normal. But once you learn pharmacology, you're going to find out, what the drugs do, right? So this is just the same. They're basically subdivided, right? Sympathetic system, right? Preganglionic acetylcholine and then norepinephrine, and this was the parasympathetic division once more, right? The two neurotransmitters responsible. They actually exert their effect. So let's say we have the sympathetic system, right? I said norepinephrine is going to come and is going to bind on the alpha receptor, right? Let's say it was alpha-1 receptor. So they will cause intracellular messages. They're usually G protein coupled. So this is called G protein coupled. The G protein coupled, another name for it is a serpentine receptor because it looks like a snake. They called it this receptor, right? Because there was 7 passes, 1, 2, 3, 4, 5, 6, 7 times and went through the membrane. the person who discovered these G protein coupled receptors and their function, they won Nobel Prize. Right? So I don't expect you to know the actual secondary messengers that go through it, but what you want to know is that eventually, right, once you trigger the specific receptor here being alpha receptor, G protein coupled receptor, there's going to be some sort of a response of the muscle or the gland that it innervates. For the purposes of the alpha-1 on the arterial side is going to cause muscle contraction. So if I contract the arterial, the tunica media, I'm going to constrict, vasoconstrict, increase blood pressures. So remember, right? So here's epinephrine coming on the beta receptors, right? You're going to have intracellular signals that's coming in. You're going to increase cyclic AMP, right, through these G protein coupled receptors. And if receptor is stimulated on the cardiac, it's going to increase metabolism, is going to increase the tone, Beta2 response, increase smooth muscle relaxation of the receptors, so bronchodilation. Beta3 response is usually in the fatty metabolism. For the purposes of the medication, you're not going to be giving many drugs that stimulate beta-3 response, but that's they release fatty acid adipose tissue metabolic use for other tissues. But the beta-1 and beta-2, you're definitely going to be masked because we have beta blockers, right? Metoprolol, atenolol, that you want to be familiar. Beta-2, right? We have albuterol. We have epinephrine that you give in your protocols. So you want to be very much familiar how they exert their effects. Any questions about these specific receptors and their inherent functions? Okay, so no questions. We're going to proceed forward, right? We talked about acetylcholine nicotinic receptors and the effect. So if it binds, however, on the muscarinic receptors, muscarinics found in the heart, the muscarinic receptors are also G protein coupled receptors, and they're G inhibitory receptors. So there's slightly different cascade of events, and this will slow down if it, let's say, it goes to the heart. It will slow down the heart rate on the parasympathetic side. So here, this is in the central nervous system. We now have discussed, right, the sensory processing, right, how the propagated to the sensory neuron, how you interpret it. We talked about in the muscle chapter, the motor centers will respond. So if I want to pick up a pencil, squeeze my muscle, the motor pathways is stimulated, the parent pathway, and you have the somatic, right, system, so the somatic effector nerves actually perform said action. On the parasympathetic autonomic side that we just talked about, the sympathetic system and the parasympathetic system. You want to be clear about the neurotransmitters, which are preganglionic, which are postganglionic, right? And the response. Can anyone tell me what is the neurotransmitter for the sympathetic division, preganglionic and postganglionic? And what effect?
Repeat that one more.
Yeah. Can anyone tell me for the sympathetic system, what is the preganglionic neurotransmitter and what is the postganglionic neurotransmitter for the sympathetic?
Pre is acetylcholine, right?
Correct. And what is the post?
Norepi?
Norepi is correct, right? And then we talked about what does norepi do for beta-1 stimulation, beta-2, and alpha-1.
Beta1 would be a constriction, increase heart rate constrictions. Beta2 would be,
Ability.
oh yeah, contractibility. Beta2 would be a bronchodilation.
Good. All right, very good. So beta-1 heart rate, all about the heart rate. Beta-2 is all usually about the lungs. Beta-2 effects also can cause some dilation of some vessels. And sometimes we would give a medication, right, to relax the uterus for the contractions. That's also beta-2 response. Alpha-1 is right. Very good. And then what is the preganglionic and postganglionic neurotransmitter for the parasympathetic division.
It's acetylcholine.
Acetylcholine is correct for both. Acetylcholine is the preganglionic and postganglionic for the parasympathetic division. They're being nicotinic on the actual muscle, skeletal muscle. And we talked about muscarinic, for example, innervates the heart, right? So all that is there. Here, I'm going to show you, this is the normal response, meaning what does your normal body response to the sympathetic stimulation, right? And what is going to happen. So here we see sympathetic effects, right? Skin, right? Beta2, we have some dilation, skeletal muscles, dilation. That's why in uterine contractions for in labor, we will give medication, retin, beta2 agonist, so that can cause it. We see that in the heart, increased heart rate and force of contraction is predominantly alpha-1 and beta-1. So if I give you beta-1 stimulant and I give you alpha-1 stimulant, I'm going to do both, increase heart rate, right? Increase contractility. I'm going to vasoconstrict with alpha-1. It's going to increase my heart rate and blood pressure, right? Here we see dilation to the lungs, beta-2, right? Which we talk about. So this is what you want to be cognizant about. Once we talk about liver, not liver, I should say kidneys, if I have it here. I don't think I have it. I do have it here. In the kidneys, we have also stimulation over the beta-1. And you're going to see, right, stimulation of the beta-1 is going to release renin. And this is important hormone in blood pressure regulation. Right? I'm going to talk about that when we get to our renal chapter. For the parasympathetic system, right? Parasympathetic system, especially the muscarinic receptors, right? If you stimulate them, they will decrease the airway diameter, right? And you will see those effects exerted by the parasympathetic division. So in opposition to the sympathetic. So this is just, you don't need to remember all of them. The one I specifically circled, you definitely need to know, right? You definitely need to know beta-1 on the heart, beta-2 on the lungs. Definitely want to know alpha-1 on the arterioles, right? You definitely want to know nicotinic and muscarinic responses. Right, and this is just the summation in terms of the responses, right? Beta-3, I said, was for lipolysis, breakdown of lipids, right, for the body's needs. Secretion of renin, as I was about on beta-1 response for blood pressure regulation. We talked about urinary restriction of the internal sphincters, right? Beta-2 and alpha-1. Talk to you about relaxation of the uterus, beta-2 stimulation for medication, right? We gave for that. So I'll give you some examples, right? Here, the parasympathetic system was what's causing the erection, and if you have no sympathetic tone, the sympathetic system is lost, right? That's why we check for priapism in those settings. So you could see how the sympathetic and parasympathetic system working together, and when you block one, unopposed effects of the other, right? And that's what we have here. Now, we learned in the muscle lecture that acetylcholine esterase was the enzyme, right? Remember I said this enzyme was chopping up acetylcholine. But now, what chops up norepinephrine and epinephrine? So they call it catechol methyltransferase enzyme that breaks down the remaining neurotransmitter that's left in the synaptic cleft. And monoamine oxidase is the enzyme that breaks up the neurotransmitter molecules and it takes it back to the synaptic cleft. So this is found in the cleft to remainder. This is what takes up the initial norepinephrine, right? And it puts it back into the vesicle, be reused again. A lot of these enzymes are target of actions states such as depression, right? Because in the depressive states, they may be lack of neurotransmitters. So they block these enzymes, right? From breaking up excessive amounts of norepinephrine, epinephrine, right? So monoamine oxidase is for epinephrine, norepinephrine. That's the enzyme that breaks up the neurotransmitter. Function is kind of similar to acetylcholine esterase. Catechol O methyl transferase is the enzyme that breaks down the remaining neurotransmitter that's found in the synaptic cleft that has not been reuptaken yet. So it's in opposition to this enzyme. Okay. Any questions about these two? All right. So now that we went through all this, right? I want to show you some medications. You're not responsible to know this right away, but hopefully you learning this information, right? You can kind of see, right, what I mean by that. So we talked about Alpha1 response, we talked about Beta1 response, we talked about Beta2 response. The plus signs that you see here, the more pluses means the higher the response. So the more heightened the response, I should, right? So these are some of the medications that are found in your protocols. So if you were looking in your protocols, definitely saw dopamine, definitely saw norep, you saw epi, norepi, right? We used to have vasopressin before in the protocols, but these medications, 1, 2, 3, are definitely found in your protocols, right? So imagine you have a patient who had a massive heart attack, and their blood pressure is now very low. Blood pressure is 70/42, right? And you give them aspirin and you give them options, but you want to increase their vasomotor tone. You want to vasoconstrict them. Remember, I drew the heart, right? And I said these were your arterioles, and I said I want to vasoconstrict them. BP 70/40, he's definitely in cardiogenic shock, but the heart just suffered a massive heart attack, right? So the heart, it's not squeezing as hard, right? It has increased myocardial oxygen, right? So if you wanted to vasoconstrict them, increase vasoconstriction, and we said vasoconstriction was Alpha1 response. Which medication would you want to give? I have dopamine, I have norepi, I have epi.
Give them epi.
Give them epi. So who said that?
John.
John. Okay. So John says in the setting of heart attack, I want to give epi. Does anyone have any alternate ideas? Anyone want to give any other drug?
I feel like I see dopamine most of the time.
Okay. So you want to give dopamine?
Yeah.
Do we have any votes for norepi? Anyone wants to give norepi? Steven, you want to give norepi?
I don't know. I'm gonna go with dopamine.
Dopamine, all right. So anyone?
We're gonna give him norepi because it's gonna act on the muscarinic receptor.
How many wants to give norepi? So
I changed to norepi. I changed my mind.
okay. So we got 1, 2, 3, right? So now we learn about all these receptors, right? And we have these drugs. So how do we go about determining what to give? Do we go any, mini, miny, mo and pick one, or how would you say we should go about doing this?
Depending on what your service carries.
I carry all three. Let's say you got your bag, you got all
Gonna
three.
give him the more potent drug, the more strongest drug gonna affect the whole receptor we need to be acting, like Beta1, Alpha1 and Beta1 and Beta2.
Helmi says, you know what? I want to hit him with the strong God. I want to hit him with all the receptors, right?
But Nick, I got a question.
Yeah.
It's a stupid question, but can you hit them with all three?
You can if you want to. I wouldn't recommend that, right? So I will explain to you when this is done, right? So let's go back. Before we get to your example, John, let me first go back. We were talking about an example where a guy had a massive heart attack, right? And he had a massive heart attack and he was in cardiogenic shock. We'll learn about all these receptors. So look, right? You have a lot of pluses means there's a lot of effects. So look at epinephrine, right? Somebody said epinephrine. Yes, the alpha response, I'm going to cause vasoconstriction. But look in beta-1 response, you also have 4 pluses. So if I have 4 pluses, do you think it's going to increase my heart rate? Is it going to increase contractility? It's going to increase velocity of contraction? And do you want to do that on the heart that just sustained an insult and has increased myocardial oxygen demand? Do I want besides the vasoconstriction by alpha-1, do I want that beat as fast and as hard as possible?
No, you want to go easy on that heart. It's sick.
Exactly. Therapy may not be my best drug right? In that setting, that drug may not be the best. So in that setting, I want to give a drug that gives me a vasomotor tone, right? That gives me vasoconstriction, but I don't want a lot of pluses on the beta-1, right? So here we see, right, dopamine, right, that gives 2 and 2, right? So then look, so if we look at the recommendation, this was, by the way, published by American Heart Association. They said in the setting of a classic shock, wet shock, right, cardiogenic shock. So the CS stands for cardiogenic shock. They want to give norepi or dopamine, right? So that's the medications they want to give. And it makes sense, right? In the setting of cardiogenic shock secondary to a heart attack, these 2 medications are going to give me alpha-1 response. It's going to give me vasoconstriction. It's going to give me some beta-1 response, but not as much as epi, because I don't want to, increase their myocardial oxygen demand. So when you're going to give your medications, the way you're going to base your decision is not eeny, meeny, miny, mo. You're going to base it on the normal physiology, right? The targets and the response, the pharmacologic profile of the medication itself, right? So and you're going to medications, you're going to look the effect it exerts, and then you're going to employ the right medication for the right patient. Now, John, you said, well, let's hit him with all 3, right? So yes, sometimes that happens. Imagine you have a patient who is in shock, right? In sepsis, right? Their blood pressure drops. They have massive vasodilation. So in the early setting, let's say I gave them norepinephrine. Let's say it wasn't enough, and they're still declining. Their blood pressure is dropping. Maybe I initiated second medication, right? We start a second medication on them to increase the vasomotor tone. Perhaps it's going to be, right? And it's still not increasing. Maybe I'm going to give a different receptor, the right vasopressin receptor. So I'm going to give them a third pressor. So that's why when you do interfacility transport, or critical care transports, you'll see those very sick patients. They're going to hit them with multi-drug, right? Multi-pressors. Why? Because it's different receptors and different response. Make sense? So if you are heading that pathway where you are not improving, they start adding other drugs to act on different receptors, right? And increase the vasomotor tone, right? And then they could also add, right, medication inopressors, which is increase contractility. You see how beta-1 is so this drug is usually also given in the setting of cardiogenic shock, right? But you got to be careful with these medications because these medications vasodilation. You see how it says -1 for alpha-1? So in a cardiogenic shock, this is not my first drug of choice, because if he is 70 over 40, I don't want to vasodilate him, right? Because this is going to come in later, but this is going to be initial phase. I'm going to vasodilate him. So in those settings, they will give him, like, say, a pressor by inopressor, which is going to increase the. So what's the whole point of this conversation? The whole conversation is, first, you guys need to learn the normal physiology, normal receptors. What's alpha-1? What's beta-1? What's beta-2? Renal chapter, we're going to spend some time talking about dopamine receptors, right? Beta-1 receptors on the kidneys, their effects. So I'll wait until we get to the kidneys, right? But this is the major stuff you need to be familiar with.